3 of them, and I'm like, okay, forget it. This isn't working.
That's why you have your shots. Your EpiPens.
Well, I slowly started the allergy immunotherapy, and the last time I took a Benadryl was probably 9-10 months ago now.
So is that good?
Yeah.
Oh, that is good.
Yeah, that is so much. I was gonna. I keep forgetting it. I was gonna bring my. Because they stay at room temperature. I was gonna bring my EpiPen, so I can bring in an EpiPen.
Well, that's too bad. You brought it in today because I did allergies or something. I don't even remember.
You're doing allergies?
Allergic reaction.
Shoot, I should have brought my EpiPen. This is what it looks like.
Yeah, this is what it feels like.
So would it just, are you allergic to peanuts? Just like put a peanut on you and then.
No. It's not. I don't have.
Does it work like that? I don't know.
Some people it does. I know a person,
Really?
Yeah, some people it does. I know a person who she'd take like lemon juice and rub it on her mouth, and she can't talk, can't do anything, just swallows her. No, I used to be allergic to. If it was green or it was growing, I was
Like
allergic.
grass?
Yeah. Well, when I first went and got tested, because I was wanting to.
How did you play as a kid?
Covered in hives.
The doctor.
Yeah.
No.
I don't know why this kid always covered in
The
hives.
doctor told my parents to move to a desert. They said
Oh
he
my
will never
gosh.
survive in this.
Well, we have grass here.
But I just they shot me up with. I used to have 2 allergy shots per season.
Wow.
And so, yeah,
That's crazy.
yeah,
I always wondered how like those kids played. I mean, obviously you can.
They just keep them in a bubble.
Yeah.
That's
But
what
like
they-
a hamster ball thing.
That's
Yeah.
what they
There's
recommend.
a movie called Bubble.
Bubble.
Yeah,
Yeah.
Old
Seen the old one?
movie.
yeah,
Charles
Yeah.
yeah, that's.
I was actually not allowed stuffed animals when I was younger.
Wow.
I was not allowed to have any kind of stuffed animals when I was younger because they put me in the hospital because of all my allergies. They took out all stuffed animals, everything. Nothing like
Action
fur,
figures?
anything like that.
Action figures? You live on.
Anything like that I was allergic to.
Wow.
It was,
That's interesting.
It's no wonder why at his age he's got the thrill to go to amusement parks and.
But those are just fun in general.
Yeah.
They're amazing.
Yeah. Then it finally kind of veered off, and I got really sick when I was younger.
Okay. All right, Katrina.
So can I just read it from here?
Yeah, you can. I mean, if you need to play it, go for it. You can just play it if you want to, and if they have questions about stuff as you're going over it,
They can't see, but they can hear.
they can hear. Yeah. I mean, it's just like that. Unfortunately, they just can't see it. I guess if you wanted, you could turn that screen around. Okay, it's just not very big. I think. Oops. Okay, it'll come back on.
Is there a remote for the projector?
Yeah.
Is there an input button on that? Can you change the input? Maybe it's on the wrong input. Maybe it's not a cord issue.
Okay, I can try it.
And I remember Dale was fiddling with the thing for like 30 minutes that one day when McGuire was here.
Yeah. Well, people use this classroom and they mess with stuff. And it's like, why do you mess with it?
It's not your touch it.
Yeah, just leave it alone. I don't know if it'll pull up. That's the thing. Cause it's not letting us do anything on that.
So you can
There we
go
go.
down to input and maybe choose a different one. Like maybe they accidentally turned it off.
That one, video, maybe?
It's hard to say which one.
I know, let's try this one.
Picture.
You can, you can jump in there.
Once turned off.
Or I could call IT and have them send someone down here. if you want.
She was calling,
Oh.
Devonna was gonna call them and ask them to come over here. Hi, how are you? That was fast. So I started to mess with this, thinking maybe something on theirs is messed up.
Tell us what you did so we can do it ourselves next time.
We exactly did. We predicted he's gonna touch one
First,
button.
this was on camera, so.
Yeah,
so
both of
I
those,
so
yeah.
I switched that, and then I just cycled through it. Usually it'll like go through itself and automatically, but it didn't want automatic, so I pressed it.
Thank you.
Thank you.
Yeah, we knew it was something simple.
No worries.
That's why they get paid. Yeah, that's
That
one
was
button.
There it is.
Medication calculation, concentration dose and application. Calculation medication dosages, concentration, and key measures. Medication calculation. Many calculations used in today's OR setting are prepared in the pharmacy and transferred to the sterile field and ready to use for. Some facilities in emergency situations, medications are prepared in the OR by the first team. Surgical techniques understand the concentration, therapeutic dose, and application for each medication on the sterile field as actively participate in various steps of medication administration. Concentration. The concentration of medication is a ratio of solvent to three components of the solution. This concentration can vary depending on the strength of the solute and the amount of solvent added to create a solution. The concentration of medication is found in the medication label and should be checked carefully for accuracy. So for medications in powder form that need to be reconstituted in liquid form for administration, commonly the type of solvent is 0.9% sodium chloride for injection. Be required to create a solution with a concentration indicated on the label. So for example, Declotan comes in 1 or 2 gram powder form that must be reconstituted. So if given intravenously 1 gram of Declotan with the sodium, it is reconstituted using a 10 ml of sodium chloride 0.9% for injection, resulting in a concentration of 100 milligrams per milliliter. And concentration medications that also come in concentrated liquid form that may be used in a concentrated form or used in a less concentrated form. So for example, heparin sodium is available in several concentrations, including 500, 1,000, and 10,000 units per milliliter. So normal saline for injection can be added to any of these heparin concentrations to make a sodium concentration. Dose. The dose is the overall amount of medication delivered to the patient. So the dose or dosage is documented in the patient's record as part of the 6-letter medication administration. On occasion, several different concentrations of the same medication are used during the same procedure. Cumulative dose of the medication should be documented. The heparin sodium can be used in different concentrations during insertion of the venous access device, dilute heparin solution, can be used per milliliters to irrigate the device and its catheter during placement. Concentrated catheter 5,000 units per milliliter is used as the final flush to maintain patency of the device and catheter while not active use. Application, which is the medications used in the surgical setting. Some medications have different uses with the surgical setting. However, lidocaine, hydrochloride, is commonly used as a local anesthetic. It can also be used as an antiarrhythmic to decrease abnormal heartbeat. The surgical tech should be worked out in under which situation each medication and therapy was used and delivered. But epinephrine is in concentrate of less than 1 in 100,000 can be injected as a vasoconstrictor, but in concentrations of 1 in 1,000 should only be used to prevent serious patient complications, including death. Calculating medication dosages. The concentration. In order to calculate concentration, you need to convert the solution to units of medication per 1 unit of fluid. In other words, solute for solvent. So this is accomplished using the three following formula. Here. So if the label reads 500 milligrams per 5 milliliters, and you would put that into the formula, and so the solution into units would be per 1 unit of fluid. There. And then we multiply the means and extremes, and then we reduce the fraction by dividing both sides by 5, and then your answer is 100. And when diluting a medication by adding more solvent to the solute, the concentration changes. So for example, 1 milliliter heparin sodium, 10,000 units per milliliter is added to 10,000 milliliters of normoxazine. So the concentration of this medication is 10,000 units per 1,000 milliliters. So you would convert this by using the same formula up here. So then you multiply here, and then multiply the means by extreme, reduce by dividing both sides by 1,000, and then you get 10 units per milliliter. This math problem is still confusing to me, but I'm slowly getting it. Cumulative dose and conversion, the total amount of medication given to the patient. So it's calculated by taking the amount of solution delivered and multiplying it by the amount of solute in the previous ratio. So a surgeon used 250 ml of heparin sodium solution in the procedure. So you would multiply that by the amount of solute in the previous ratio. So in the previous ratio, the answer was 10 units per ml, and then times it by the amount of solution given to the patient. So your answer would be 25 units of heparin sodium total given to the patient. And another common calculation using OR is the conversion of patient weight between the more familiar apothecary system accounts to the more accurate metric system. So this conversion used formula 2.2 pounds equals 1 kilogram. So to convert pounds to kilograms, divide the number of pounds by 2.2. 185 pound patient would weigh 84.1 kilograms. So 185 divided by 2.2 equals 84.1 kilograms. So for an emergency situation, the weight can be divided in half to transmute the first digit of the answer from the answer. So half of 185 gives you 93. You subtract 9, so you get your 9 from the first digit of the answer, and it gives you 84 kilograms too. Which I think this one's easier.
I don't know why it was blurry.
I don't know.
Rachel's was like that too. This was real blurry. I looked at it and it was blurry at all. You guys have any questions about calculations? They're confusing?
Confusing.
Yeah, so just know that when you have to calculate, like heparin, somebody will help you. You're not gonna be just thrown in there, but here we need. Yeah, you got anesthesia who's excellent at figuring calculations. You've got the surgeon who will help you, if they're in the room. And if not, because usually it's you and the circulator in the room, the circulator will go over it with you. So, and after a while, you get to know how much of, this you put with this. You'll know. All right, so yeah, nobody's gonna expect you to know any complicated math calculations. The thing that I can remember that I had to calculate was heparin. That was probably about the biggest thing. Everything else, like local, when you're giving a half and half solution, that's what it is, half and half, it's half of this and half that. So those are always really simple, but heparin it can be a little bit confusing. So in that case, ask for help. Don't ever be afraid to ask for help when you're doing something like this, okay? Because the surgeon relies on you to give him exactly what he needs. So if you have put too much heparin or epinephrine or anything in it could kill the patient. So yeah, anytime you're in doubt, just ask for somebody to help you and tell the surgeon how you mixed it. If they have any questions, they'll tell you, throw it out, hopefully do it. Okay, and that's fine. Let's see, who do we leave off on? Shayna, right?
Oh, yes. All we gotta do is push play, so.
Come on, Shayna, don't you want to come and push play?
I'll push play.
No, I can't.
I'd be happy to. I mean, we should probably refresh it
Work on
first.
some questions.
Probably refresh it first.
Yeah, just in case. You guys don't want to miss what I say. No, I'm just
No
kidding.
way. But we're glad that you're here so you can clarify stuff for us if we have any questions.
Here is my presentation on cricoid pressure through cardiac arrest. Cricoid pressure, also known as the Selig maneuver, named after Brian Arthur Selig. This maneuver is designed to prevent the stomach contents released into the esophagus from entering the laryngeal pharynx, thereby reducing the risk of aspiration into the respiratory tract. Cricoid pressure is employed in situations when the patient requires emergency surgery shortly after eating, the MPO status of the patient cannot be verified, or the patient is experiencing gastrointestinal bleeding. Cricoid pressure may also be applied during basic life support settings as needed. Selig's maneuver is performed to reduce the risk of aspiration. And in order to do so, you will apply firm pressure with the thumb and the index finger forming a V to the cricoid cartilage, which is located inferior to the prominence of the thyroid cartilage. The external pressure causes occlusion of the esophagus between the cricoid ring and the body of the sixth cervical vertebrae. Cricoid pressure must be applied prior to the induction of anesthesia and continues until the endotracheal tube is placed, the correct position of the tube is verified, and the cuff of the endotracheal tube is inflated. The individual placing cricoid pressure does not release the compression until directed to do so by an anesthesia care provider controlling the airways. Laryngospasm and bronchospasms are reactions demonstrated by the lightly anesthetized patient. A slight trigger of the GAD reflex results in a spasm or rigidity of the upper respiratory tract, resulting in an inability of the patient and/or an anesthesia care provider to move air and waste gases in and out of the lungs. This may occur during induction or the emergence from anesthesia and can lead to a total airway obstruction, which is treated with positive pressure breathing. If positive pressure breathing does not provide relief, the patient will be given succinylcholine, which is an ultra-rapid acting neuromuscular blocker, which is used to relax the spasm, and the patient will need artificial respiratory support and monitoring until independent respiratory ability returns. Malignant hypothermia, MH, is a potentially fatal hypermetabolic state of muscle activity. During this hypermetabolic state, The striated skeletal muscles are stimulated to contract, but due to an abnormal release of calcium within the muscle cells, the muscles cannot relax, resulting in rigidity, heat generation, and a buildup of lactic acid and carbon dioxide. MH is a genetically transmitted disease, more commonly seen in males than in females, and can be triggered by the use of acetylcholine, urare, and halogenated inhalation agents. The first sign of an MH crisis is unexplained tachycardia followed by tachypnea and is increased level of carbon dioxide. Shortly thereafter, an unstable blood pressure, perspiration, muscle contraction, and cyanotic morbid skin are demonstrated. A late sign of MH crisis is a rise in temperature, sometimes as high as 107 degrees Fahrenheit. Supplies for the treatment of MH crisis should be readily available, and all staff should be familiar with the location of the supplies and the treatment protocol. The treatment interventions for a patient in MH crisis include the discontinuation of anesthesia administration and the oxygenation of the patient with 100% oxygen. A non-triggering anesthetic agent may be given. Dantrolene sodium, or Dantrium, is a pharmacological agent administered specifically for the direct treatment of MH crisis. It is reconstituted using sterile injectable water and is given IV. A loading dose of 2.5 milligrams per kilogram is given, followed by a dose of 1 milligram per kilogram every 5 minutes until a maximum dose of 10 to 30 milligrams per kilogram is reached. Additional interventions include the administration of chilled IV fluids of normal saline or dextrose in water. The chilled saline lavage of all body cavities is performed if exposed. Take note that the bladder is not irrigated to permit accurate monitoring of the urinary output, and make sure the patient is tagged with eyes along the heat transfer points. And care needs to be taken that as the crisis diminishes, the patient does not become hypothermic. Other treatment interventions during MH crisis include the administration of sodium bicarbonate to assist in metabolic and respiratory acidosis regulation, dextrose and insulin to provide available glucose to the cells to maintain cellular metabolism, furosemide or mannitol to promote renal clearance of waste products, and heparin to prevent intravascular clot formation. And an indwelling Foley catheter attached to a uremitter is inserted into the urinary bladder to monitor urinary output. Acetylcholinesterase deficiency syndrome is a genetically transmitted trait that decreases the amount of acetylcholinesterase available in the neuromuscular junction to break down acetylcholine during muscle stimulation. Acetylcholine remains effective in the neuromuscular junction, permitting prolonged effect of depolarizing neuromuscular blockade. This prolonged effect can last for several hours after agent administration. There is no direct treatment for acetylcholinesterase deficiency beyond respiratory support of the patient until the body eliminates the neuromuscular blockade. Prophylactic treatment includes avoiding the administration of depolarizing neuromuscular blocking agents and notifying anesthesia care provider of the syndrome prior to the future anesthesia administration. An allergic reaction is the result of a histamine release in response to exposure to an allergen or triggering protein. An allergic response may be mild, such as a skin irritation, or a life-threatening anaphylactic reaction. Anaphylaxis is an immediate hypersensitive reaction resulting in respiratory distress that leads to vascular collapse and shock. The patient's history should include any prior allergic reactions, and those substances should be avoided if possible. The treatment for an allergy will vary according to the severity of the reaction, ranging from the use of diphenhydramine, the use of pressors, such as ephedrine, to maintain body pressure, and steroids to reduce the immune response to the antigen.
Oh, and we
Right
reached
in
fresh.
the Right in the middle.
I know.
We're trying to be proactive.
is my presentation on typhoid pressure through cardiac arrest.
It's the third one to the back.
Which one?
From the third from the
Typhoid
end.
pressure, also known as systolic number. Shock is an abnormal physiological
fine.
state indicated
Is that
by
good?
the presence of reduced cardiac output, tachycardia, hypotension, and diminished urinary output. This state may be induced secondary to severe tissue damage, significant blood loss, infection, or anesthetic agent administration. The goal in the treatment of shock is to promote optimal circulatory volume and function. This may be accomplished by a pharmacological treatment, including cardiotonic agents, to increase the contractility and output of the heart in the treatment of cardiogenic shock. IV fluids, colloids, plasma expanders, and blood products to treat hypovolemic shock, and antibiotics and IV fluids to treat septic shock. The treatment of shock may also involve a surgical intervention to limit blood loss or treat infection. Cardiac dysrhythmias involve abnormal heart rate or rhythm. Evidenced by electrocardiogram monitoring, the dysrhythmias may be atrial or ventricular in origin, and some may be deadly if untreated. Dysrhythmias can also be triggered by the combination of anesthetic agents administered to the patient. Life-threatening dysrhythmias include ventricular tachycardia and ventricular fibrillation. The treatment for cardiac dysrhythmias include the IV administration of lidocaine hydrochloride. Additionally, defibrillation and pacemaker insertion may be necessary. Cardiac arrest involves the cessation of heart pumping action and blood circulation. This, in turn, prevents the delivery of oxygen and glucose to cells for metabolism and the removal of waste, resulting in a metabolic and respiratory acidosis. The initial treatment for cardiac arrest is CPR, followed by advanced cardiac life support, ACLS.
Didn't seem like it was getting better.
It looks like it's clear, but then again, that's pretty big. So.
Yeah. I don't want to mess with too many buttons in on that. You guys have any questions about any of that? No?
So in the operating room, they always, and probably on most floors in the hospital, they have a cart. It's called an MH cart.
Yeah, so if ever a patient does have MH, there's a cart with dantrolene and everything that's available to treat it immediately because it's life-threatening, and you have just a matter of minutes to start administering dantrolene. So.
Is that what they would call a code? No, code use.
And like I said, I've never seen anybody who had MH, so, you know, it's pretty rare. It doesn't happen very often. And if they have any suspicion that you or your family might have a history of MH, they'll know to avoid certain types of anesthesia. They probably give you a spinal. All right, Jennifer's is next. And let's see if I can find it. It's towards the end. Maybe if I just leave it on the screen like that, we'll try it.
Hi, this is Jennifer Peterson. I'll be discussing the anesthetic agents today. So let's go ahead and hop right in.
Hop in.
So today's contents will pertain to inhalation agents, intravenous agents, and local/regional agents. Inhaled agents do cross over via the respiratory system to the bloodstream through the alveolar membrane, and that's while it's in its gaseous state. While any gas waste is what excess gas is called, And it is removed from the OR environment via the scavenge system. And it does prevent occupational exposure to the healthcare workers. Oxygen is not considered an anesthetic agent, but it is a component, and of course, it's essential for survival for the patient. Nitrous oxide is clear, colorless, and does have a pretty odor. It is considered a true gas. Its potency is pretty weak, but that's why it's used in conjunction with others. It does have free diffusion. And also in post-operative, it does cause patients often to have nausea and vomiting. So with the volatile agents, they consist of a group of liquids. They do have potent vapors that when inhaled produce general anesthesia through the CNS depression and decrease EEG activity. They do assist in decreasing the muscle tone so that there's more ease of exposure to the surgical site. One of those examples is sevoflurane, which is an odorless inhalation agent. And it is rapid and smooth onset and recovery, makes it ideal for adult and pediatric patients. There is also desflurane, and it does have a pungent odor, contradicting its use during inhalation induction. It provides a rapid onset and recovery. Isoflurane is a halogenated inhalation agent that provides a moderately rapid induction and recovery. That one is going to cause hypotension, and it is a profound respiratory depressant. Then we are at the enflurane and halothane, which are less commonly used inhalation agents. Both agents do have a pleasant, non-irritating aroma, and they are rapid acting. They can cause alteration in renal function with the enflurane. The halothane can produce profound muscle relaxation and bronchial dilation. But they may induce hepatitis in adult surgical patients. Halothane is a potent urine muscle relaxant and therefore should never be used on pregnant females. So with intravenous agents, they are delivered directly to the bloodstream and act quickly. They are done with this through a catheter in the peripheral vein of the upper extremities. They are metabolized via the liver and excreted by the kidneys. And a couple of those examples that I'm covering today are induction agents and dissociative agents, but there are many more. So induction agents are rapid transition. They go from consciousness, stage 1, to unconsciousness, stage 3, very quickly. They pass through stage 2, which is incitement and delirium, rather quickly. The first one here is propofol, and it is a sedative hypnotic agent. And due to its milky appearance, it is called milk of amnesia. It can be used as an unconscious medication, but it can also produce conscious sedation. They don't create a prolonged hangover, so to speak, effect. Etomidate is considered a non-barbiturate hypnotic agent, which is used for the anesthesia induction. It does tend to be the preferred agent for anesthesia induction with hemodynamically unstable patients. The thiopentyl sodium is short-acting. It is potent barbiturate. It states here that it does not provide anesthesia or muscle relaxation, but does have hypnotic, amnesic, and sedative effects. It does leave patients with that hangover effect that can prolong the patient's emergence and recovery phases. Methohexol sodium is similar in action to propofol and thiopentyl sodium. It does have an ultra short onset and duration of action, which makes it agent of choice for treating short-term loss of consciousness. All right, so dissociative agents, they are selectively interrupting the associative pathways of the brain. So patients may appear wide awake, yet they are unaware of their surroundings. Ketamine HCl is the most commonly used dissociative agent, and it is administered via IM or IV. It produces a rapid induction of the dissociated and amnesic state. Generally, muscle tone is increased. This does conclude my presentation out of the surgical technology for the surgical technologist book with the positive care approach. Have a great day.
So something to remember about ketamine is that the major disadvantage is that it's vivid, imaginary, and morbid hallucinations during administration and recovery. So,
But it gives you better muscle tone, right?
yeah, better muscle tone.
It's worth it. It's worth it.
Yeah.
Do certain surgeons have like certain anesthesiologists have certain preference? Hey, we're doing this procedure. They have certain anesthesias they like to use.
So usually what anesthesia is going to do is they're going to have a consultation with the patient. They like to do it like kind of depending on the surgery, but they like to do it maybe a few days before they actually have surgery and talk about like family history, any kinds of problems that they're having, and they decide what type of anesthesia. Anesthesia does anesthesia. And they might discuss with the surgeon what they're going to do, but it's up to anesthesia what they give them, and the surgeon just respects that. During the procedure, if the patient is waking up, if they're not relaxed, the surgeon will ask them to relax the patient, so they give them something to relax their muscles, because if they're stiff while you're doing surgery, it's hard to retract, and the surgeon can tell. When you're like fighting to retract, then the surgeon will say, okay, I'm done fighting this. Please give this patient some muscle relax. So, yeah, other than that, anesthesia
is a charge.
Yeah, they know what to give, how much to give based on weight and patient's health. All right, any questions about that presentation? Oops. Okay. All right, then the next one is Crystal. Oh yeah, Crystal's there.
Crystal Is that right below? Yeah.
Yeah, it won't, see how it is, it won't come up. I have to go to my mailbox and get it. So did it seem like it was clearer just keeping it on the screen like that? Or about the same? About the same? I don't know what's going on. I'll have to look into that too.
The opiate opioids are a group of narcotics classified as analgesic, which also produce sedation. They act by binding to the CNS and spinal cord receptors, producing a decrease in pain impulse transmission. Euphoria or a feeling of happiness and well-being may also be experienced, thereby also reducing surgery-related anxiety. High doses of the agents may lead to a loss of consciousness and respiratory depression. Opioids do not produce muscle relaxation, but rather they tend to increase overall muscle tone. Opioids are commonly used as an adjunction to general anesthesia agents, permitting the use of lower, safer concentrations of inhalation agents. Occasionally, opioids are used as a sole anesthetic agent, as in sometimes used during cardiac surgery. They are biotransformed primarily in the liver and eliminated in the urine. All opioids and opiates are controlled substances regulated by the FDA. The effects of opioids can be reversed by the administration of naloxone Narcan, which works by competing for CNS receptor sites, preventing opioid binding. Naloxone HCl given IV leads to an abrupt onset of pain as the opioid previously administered no longer provides pain relief. This may cause tachycardia and hypertension. Because the effects of naloxone usually last 15 to 30 minutes, which is usually shorter than the effects of the opioid, patients should be closely monitored for opioid-induced rebound respiratory depression. Benzodiazepines are sedative tranquilizers used in anesthesia in two ways: to reduce the anxiety and apprehension of the preoperative patient, and as an adjunction to general anesthesia to reduce the amount and concentration of other more potent agents. Sedatives do not produce anesthesia. The most commonly used sedatives come from the benzodiazepine groups and are used for their ability to produce amnestic, anticonvulsive, hypnotic, sedative, and muscle relaxation effects. Hypotensive changes and respiratory depression may occur, especially when benzodiazepines are administered with an opioid agent. The two most commonly used benzodiazepines are diazepam, Valium, and Versed. The effects of benzodiazepines may be reversed by the administration of Flumazenil. Flumazenil works by competing for benzodiazepine inhibitory receptor sites. Flumazenil has a rapid onset of action and reverses the sedative effects, but may not reverse the amnesia effects. Convulsions may also occur with Flumazenil administration. Patients need to be addressed and monitored for rebound sedation and or respiratory depression. Skeletal muscle relaxants or neuromuscular blockers, NMBs, interfere with the passage of impulses from motor nerves to skeletal muscles, resulting in muscle weakness and paralysis. Jaw relaxation is achieved to facilitate endotracheal intubation. The muscles of respiration are affected, allowing for mechanical ventilation, and the musculature at the surgical site is relaxed to allow tissue retraction for surgical exposure. Administered IVs, NMBs, serve as an adjunction to a general anesthesia agent, permitting a decrease in dosage and concentration of a more potent agent. Depending on the agent's onset and duration, NMBs are commonly re-administered throughout the surgical procedure.
The blockade effect is monitored by the use of a peripheral nerve stimulator. Neuromuscular blockade must be naturally or pharmacologically reversed prior to extubation to reverse the respiratory muscle paralysis. Non-depolarizing agents work by competing for postsynaptic receptor sites at the neuromuscular junction. This competition prevents acetylcholine from being able to stimulate muscle contractions. Spontaneous recovery of neuromuscular blockade may occur as the agent diffuses from the receptor sites into the synapses. Non-depolarizing agents may also be reversed by the administration of agents that inhibit acetylcholinesterase, the enzyme that breaks down acetylcholine. Depolarizing agents work by mimicking a release of acetylcholine across the neuromuscular junction. The agent binds to the postsynaptic receptors, causing muscle contraction to occur, which is followed by a period of muscle fatigue. The contraction relaxation cycle in the muscle is strong enough to be visible. The action is referred to as fasciculation, and the patient may experience post-operative muscle ache because of the strength of the fasciculation. The effects of depolarizing agents cannot be pharmacologically reversed.
All right, any questions about those? This is next. Let me see.
Other agents used during anesthesia administration: antimuscarinic agents. Antimuscarinic, formerly known as anticholinergic agents, act to block the cholinergic effects of certain drugs or stimulations of the parasympathetic nervous system, including excessive salivation and bradycardia. The two most commonly used agents are atropine sulfate and glycopyrrolate robenol, and non-steroidal anti-inflammatory drugs. Ketorolac Toradol is an NSAID used for moderate pain control. This agent is given IM to aid in pain management during emergence and recovery. Gastric acid management. Histamine antagonists and antacids are agents used to alter the pH of gastric secretions and reduce gastric volume. They are given during the preoperative or intraoperative period. Included in this group are the oral agent, citric acid, Lecetra, and the IV agents, cimetidine, Tagamet, and ranitidine, Zantac. Metoclopramide, Reglan, a cholinergic agent, can also be used to promote pyloric emptying. Lubricants. Lubricants are used to protect the cornea when the eye is unable to close or when natural lubrication of the eye is impaired. Lubricants such as Lacrolube or Durotears are used when general anesthesia is administered to prevent corneal dying. Antiemetics. Antiemetic agents are used to prevent post-operative nausea and vomiting. Droperidol, Ensopine, metoclopramide, Reglan, Ondansetron, Zofran, Durancetron, Kytrel, and Delancetron mesylate. The enzymatic have antiemetic properties and are usually given by intravenous injections. Solutions used in the operating room setting. Many pharmacological agents used during anesthesia administration are delivered directly into the bloodstream. Access to the vascular system during a surgical intervention is maintained through the use of a peripheral or central venous catheter. Patency of the vascular catheter is maintained using an infusion of intravenous solutions. These solutions include Ringer solution. Ringer solution is a water-based solution for injection that contains essential serum, electrolytes in the forms of sodium chloride, and calcium chloride, and is physiologically similar to plasma. Lactated Ringer's solution. LR has sodium lactate added in addition to the electrolytes, which enables it to serve as a glucose source for body metabolism. Both Ringer solution and LR are used to correct fluid and electrolyte deficits and mild acidosis. 5% dextrose solutions, D5W. D5W is a solution of water with a 5% concentration of dextrose monohydrate added that serves as a source of glucose, sugar normally obtained by eating. D5W is used to correct hypoglycemia and replace water loss during normal metabolism. 0.9% solution, normal saline. Normal saline is a solution of water with the addition of sodium chloride. Normal saline is used to correct deficits of sodium and chloride and treat metabolic alkalosis. It is used in the OR when blood or blood products are being administered.
So those are all, really common in the OR. We pretty much almost always will use sodium chloride as our solution on our back table. Anesthesia almost always uses LR. So you'll just get used to seeing that all the time. You guys doing okay? You need a break? All right, let's take a break. Resume.
Topical and local anesthesia. Topical is the placement of nerve conduction blocking agents either on the skin or in the mucous membrane. Local anesthesia is the injection of nerve conduction blocking agent in tissues and or directly on the nerves. This can mean that the patient will be monitored throughout the procedure using monitored anesthesia care, which is also known as MAC. And this is just a sedative or analgesic that will help the patient. Regional anesthesia is nerve plexus block, which is injected into the region of major nerve plexus. It can also be a veer block or a spinal block. When using a veer block, the extremity is first rendered bloodless by constriction and elevation. Use of the tourniquet throughout the procedure ensures that the anesthetic agent remains in the desired area. Procedures that will use the veer block would be a carpal tunnel release and a trigger finger. Please note that you must exsanguinate the extremity and use an S mark to do this. A tourniquet is used. Usually mild sedation will also be used. Finally, agents are injected intravenously through the dura mater into the subthoracic space, usually in the lumbar spine area. Some procedures that use spinals are TURBs, lower leg vascular, so embolectomies, C-sections, and the effect is it anesthetizes the entire lower body. Epidural clotting box. An anesthetic agent is injected into the space surrounding the dura mater. This procedure is used for vaginal or cesarean section. It's a single injection or a catheter may be placed for continuous injection. Also blocks, like Cottle blocks. This is for vaginal childbirth. It's injected into the epidural space via sacral canal. It helps in most procedures. It helps to relieve labor pain, And it also helps with post-operative pain relief.
Common question is, what's the difference between an epidural and a spinal? The differences in the techniques are best illustrated graphically. First, the epidural. The epidural space is located within the spinal column, just outside the dura, a layer of tissue that surrounds the spinal fluid. The tip of the needle is placed into the epidural space. The medication may be injected directly through the needle, but usually a tiny flexible plastic tube called an epidural catheter is threaded through the needle into the epidural space. The needle is then removed, and the catheter remains in place so that additional medication can be given through the catheter as needed during labor and delivery. The spinal space is located about 1/4 inch deeper than the epidural space. It's inside the dura and contains the spinal fluid. When the spinal is done, the needle is inserted directly through the dura into the spinal fluid. Once the needle tip is positioned, the anesthetic medication is injected, and then the needle is removed.
Then there's extremity blocks. The extremity is blocked according to the surgical site. An example would be the median, radial, or ulnar nerve may be blocked on an upper extremity. These are usually done on short cases. Procedures that you will see this done on would be distal arms and legs, hands, fingers, feet, and toes. Retrobulbar block. Procedures, usually cataract, and this is injected behind the eye into the muscle cone. It provides a motionless, anesthetized eye.
The retrobulbar block is a regional block utilized by both the anesthesiologist and ophthalmologist to provide local anesthesia for patients undergoing intraorbital procedures. It is particularly valuable for surgeries involving the cornea, lens, or anterior chamber of the eye. Obtain and set up all necessary equipment for the retrobulbar block prior to beginning the procedure. Lay out several alcohol wipes and 4x4 cotton gauze squares. You will need local anesthetic for infiltration into the orbital muscle cone. Here we have drawn up a 50-50 mixture of 2% lidocaine and 0.75% marcaine in a 5 milliliter syringe. Use an Atkinson 25 gauge retrobulbar needle with blunt tip for injection. With the patient lying supine, clean the lower eyelid and infraorbital skin with an alcohol wipe. First, check that all appropriate monitors are placed on the patient, then administer sedation. Ask an assistant to elevate the upper eyelid to increase your visualization of the orbit. Palpate gently below the patient's eye to identify the inferolateral border of the orbital rim. The needle will enter the skin at the infraorbital notch, a point at the junction between the medial 2/3 and lateral 1/3 of the inferior orbit. Insert the needle approximately 2 centimeters, keeping it perpendicular to the plane of the face, such that it traverses the path of the orbital floor. Advance the needle until you hear, and possibly feel, a distinct pop. This indicates you have passed through the orbital septum. Redirect the needle medially and superiorly toward the apex of the orbit until a second pop is felt. The second pop occurs as you pass through the sheath surrounding the orbital muscles and into the muscle cone. Carefully aspirate the syringe to ensure that the needle tip is not located in an artery or vein. Slowly inject 2 to 4 milliliters of the anesthetic mixture. Watch the eye carefully. As the anesthetic is injected, the increasing volume under the orbit causes slight proptosis. As you withdraw the needle, inject 1 milliliter of anesthetic to provide anesthesia to the orbicularis oculi muscle. Close the patient's eyelid and cover it with 2 pieces of 4x4 gauze. Gently massage the globe to achieve adequate spread of the local anesthesia. This increases both sensory anesthesia as well as ocular muscle akinesia. After massaging for 1 to 2 minutes, open the eyelid and examine the eye. The sclera should be white. If there is evidence of partial or complete subconjunctival hemorrhage, a retrovulvar hemorrhage may be present. Also, palpate the eye to ensure there is not an increased amount of tension within the globe, as this too may be evidence of hemorrhage behind the eye. If the appearance and tension of the eye are normal, continue to massage the globe for approximately 5 more minutes. This allows sufficient time for the block to take complete effect.
Yeah, but their eye's gonna hurt like crazy when they wake up.
Yeah, on the eye.
Oh, I was like,
Retrovulvar block. Local anesthetics are administered to the immediate surgical site. Local anesthetics interfere with sensory nerve endings in the operative area, thus they block transmission of pain impulses to the brain. Some common local anesthesia is lidocaine and marcaine. Lidocaine, also known as lidocaine, comes in strengths of 0.5, 1, 1.5, and 2% with or without epinephrine. The epinephrine is usually in strengths of 1 to 100,000 or 1 to 200,000, and is pre-mixed into the lidocaine. Lidocaine is fast-acting and rapidly metabolized, usually lasts 30 to 60 minutes. If epinephrine is included, it will last 2 to 6 hours. Epinephrine causes vasoconstriction, thereby slowing the removal of lidocaine from the injection site. Bupivacaine, also known as marcaine or sensocaine, comes in strengths of 0.25, 0.5, and 0.75%, and it's 4 times more potent than lidocaine, and it lasts up to 4 hours. Some common anesthesia equipment. Of course, an anesthesia machine. It provides a combination of inhalation agents, respiratory support, and sophisticated monitoring. Airway delivery and maintenance devices. Ventilators, which is mechanical ventilation. It allows anesthesia to control the volume and respiration during the procedure. The endotracheal tubes, also known as ET tubes, are placed through the nose or mouth between the vocal cords into the trachea to provide a patient airway. Laryngeoscopes are used to facilitate the placement of ET tubes. Stylet is used to modify the curve or to support the ET tube during insertion. Also, an LMA, which is a laryngeal mask airway. It provides a simple and effective airway. This is usually used on shorter cases. Electrocardiogram is non-invasive and it monitors the rate, rhythm, and electrical conduction of the heart. A blood pressure monitor, it monitors systolic and diastolic pressure. Arterial and venous catheterization is an invasive monitoring device. It's placed in the pulmonary artery through the right side of the heart and it monitors cardiac output. The central venous pressure, CVP, is also invasive and is placed into the right atrium and it monitors blood pressure in the vena cava and the right atrium. Temperature monitors are non-invasive and invasive. Monitors would be forehead and ear, those are non-invasive, and the ones usually seen in the operating room are esophageal, bladder, and rectal probes. Also, pulse oximeter, it monitors blood oxygenation in arterial blood. A sensor is placed on the fingertip. Bispectral index, BIS, monitors the level of anesthesia. It monitors brain waves through a sensor on the forehead. It also monitors the level of consciousness. SARA, System for Anesthetic and Respiratory Analysis, monitors the physiological, respiratory, and anesthetic gas levels. Stethoscope is typically used in the operating room to help monitor the proper placement of a DT tube. Doppler is used to identify and assess vascular status. It magnifies the sound of blood while it's traveling. Peripheral nerve stimulator assesses the level of neuromuscular blocking by muscle contraction. This is done by stimulating the ulnar nerve. This is a non-invasive. Electrodes are placed on the medial aspect of the wrist, and this causes the muscles of the hand and the fingers to contract upon stimulation. And they use this because there's no blocking agent that is affecting the nerve impulse for this contraction. And then arterial blood gases, this monitors the pH of oxygen saturation and carbon dioxide levels. This is an invasive monitoring, and it accesses the radial artery by placing a monitoring line into the radial artery. It directly monitors the blood pressure, and it also can be performed via an A line.
That looked painful, huh? It's just a quick little video on vital signs.
A nurse working at a clinic walks into the exam room and finds a person lying on the floor. The first thing the nurse does is take the person's vital signs. Why? Because knowing what a person's vital signs are will tell the nurse what to do next. What are vital signs? Vital signs are the evidence of the current physical functioning of the body. They provide critical information that is vital for life, and so they are called vital signs. In an emergency, the patient's heart rate is the first vital sign checked by a nurse. The nurse wants to know if the person's heart is beating and at what rate. Next, the nurse will check for the person's respirations and get a blood pressure cuff to check the blood pressure. The last vital sign is temperature. There is a range of numbers provided as the norm for each vital sign. These normal ranges include heart rate of 60 to 100 beats per minute, respirations of 12 to 18 breaths per minute, blood pressure of 90/60 to 120/80, and temperature of 97.8 to 99.1 degrees Fahrenheit, or 38 to 38.5 degrees Celsius. Note that these ranges are the norms for the adult population. A healthcare worker will also look at the normal levels for the patient. Some patients' norms vary slightly from the norms listed above. For example, a softball player may have a slower heart rate. This is because of the athletic conditioning the softball player has achieved. The heart is a muscle, and it has learned to function at a lower rate. Vital signs can provide the information needed by the healthcare professional to take care for the needs of the patient. The alteration of vital signs in a patient can indicate an acute or chronic medical problem. The more off the norm the vital signs are, usually indicates a sicker patient. When taking vital signs in a non-emergency situation, the room should be quiet and the patient should be as comfortable as possible. If possible, the vital signs should not be taken for at least 5 minutes after the patient enters the room. This is to avoid getting a reading that is altered due to activity. Of course, if the patient is very ill, this may not be feasible. The patient should be seated when taking his or her vital signs. Take a moment to look over the patient. If the patient is anxious or in pain, this may cause alterations of the vital signs. The order of taking the different vital signs is not important in a non-emergency medical situation. Usually, in a patient who is not critical, The healthcare worker will take the patient's temperature first, which is a measure of how the body generates and eliminates heat. There are several different ways to measure temperature in a patient. 1. Oral. A thermometer is placed under the tongue in the patient's mouth. Temperature is measured with a glass thermometer that is visually read or with an electronic device that provides a digital reading. Patients should not eat or drink anything prior to measurement. If using a glass thermometer, make sure it is clean and shake the thermometer to get the mercury level below 95 degrees. Hold the thermometer under the patient's tongue for 3 to 4 minutes for a glass thermometer or until the unit beeps for an electronic device. A digital thermometer is the preferred method for measuring an adult's temperature. 2. Anal. Using a glass or digital thermometer, healthcare professionals will lubricate the thermometer and place it in the patient's anus about 1 inch. Note that the anal reading will be 1 degree higher because it is higher than the core temperature. So if the reading is 99, the recorded temperature would be 98. This is the preferred method for taking a child's temperature. 3. Axillary. The healthcare professional places a digital or glass thermometer under the patient's arm. Note that the axillary reading will be 1 degree lower because it is not a core temperature reading. So if the reading is 97, the recorded temperature would be 98. 4. Tympanic. For this reading, a special thermometer is inserted into the patient's ear. These are electronic, so the unit will beep when the reading is completed. 5. Skin. A strip thermometer can measure the temperature of a patient's skin. Since this is the least accurate method of taking a patient's temperature, healthcare professionals will only use it when there is no other way to obtain a patient's temperature. 6. Temporal. A special digital thermometer is used for this reading. The device is placed on the forehead and swiped along one side of the face. It is then held until the unit beeps. Measuring the number of beats in a minute is how the heart rate is recorded. This measurement is usually known as BPM, or beats per minute. The heart rate can be taken at any large artery in the body, although it is usually taken at the radial artery in the wrist. To measure BPM without a monitor, you place your index and middle finger just above the patient's wrist, in line with the thumb. Push gently at first, then apply slight pressure once you feel the pulse. Make sure not to use your thumb to avoid confusing the patient's pulse with your pulse. Count for 1 full minute to get the most accurate reading. Today, there are many electronic devices to measure the heart rate. Some are very accurate, but a healthcare worker should always do a radial pulse measurement to compare to the digital reading. Measuring the breaths per minute, or RR, respiratory rate, is the way to record respirations. This is done by counting the number of times the patient breathes in 1 minute. When taking this measurement, be careful not to alert the patient. If the patient feels like he or she is being watched, she or he may alter the rate of breathing. The best way to count respirations is to do it immediately after you take the pulse measurement. Do not let go of the wrist, but start to count the rises and falls of the chest. 1 respiration is counted for each rise and fall of the chest. This way, the patient will not become aware that you are counting respirations and alter his or her breathing. Blood pressure is measured using a manometer and a stethoscope, or using a digital device. The reading is measured in millimeters of mercury, mmHg. The first number is the systolic number, which represents the contraction of the heart. It indicates the maximum pressure on the blood vessels. The second number is the diastolic number, which represents the minimum pressure on the blood vessels. This is when the heart is resting before the next contraction. Digital devices are specifically designed to be applied to the upper arm, the wrist, the thigh, or the ankle. Because digital devices have less than 50% accuracy, the measurement for blood pressure will be described using the manometer and the stethoscope. The patient should be seated and the arm should be bare. The cuff length should be measured against the patient's arm circumference. If the cuff does not fit properly, you may receive an incorrect reading. The cuff is placed on the upper arm of the patient on the patient's brachial artery. According to the American Heart Association, the cuff is inflated to the level of at least 30 points above the patient's normal systolic reading on the manometer using the bulb. At the same time, the healthcare worker places the stethoscope in his or her ears and the bell on the patient's brachial artery. Slowly, the cuff is deflated. The first sound you hear is the systolic blood pressure, and the last sound you hear is the diastolic blood pressure. These 2 sounds represent the 2 values of the blood pressure reading. Sometimes you may not hear the last sound. If this happens, deflate the cup completely before repeating the procedure. If the measurement is very low or very high, repeat the procedure after deflating the cup. Vital signs are measurements of the current physical functioning of the body that can indicate acute and chronic conditions in a patient. The healthcare worker should always verify the heart rate, respirations, and blood pressure through manual methods if the norms are high or low. There are 6 different methods to take a person's temperature. For adults, the oral method is preferred to get the temperature. In children, the preferred method for the temperature reading is the anal method. Heart rate measures the number of beats in a minute. Using a patient's radial artery is the most efficient way to measure heart rate. Measuring of a patient's respiratory rate is done by counting the number of times the patient breathes in 1 minute. Blood pressure is measured using a manometer and a stethoscope, or using a digital device.
So that was vital signs in a nutshell. Yeah, I'm not sure what happened to that guy. He's just the picture they chose.
So if the temperature strip is not completely method, why in the world do they use the scanner?
I'm not really sure
I don't
why.
like it when they use it on my kids at the doctor's
The
office.
strips.
Yeah.
Yeah.
Or like they use the
Oh, that.
head thing and
I don't know about that one. That one might be more accurate than the actual one that they stick, like they stick on their head, the tape.
I guess I don't see how it is.
Yeah.
Makes sense. I mean, I know.
I think
like,
it's within a role,
it's not a
reasonable range.
It's a lot faster to use it.
Yeah. I see them use the ear ones a lot too for kids.
Isn't that one can be used by, because I've seen it used behind the ear too.
The head one.
Yeah.
Is, yeah.
I've seen it pressed
yeah.
up, yeah.
Yeah. All right. What kind of questions you guys got about that stuff? A lot of stuff, huh? Yeah. So do you guys, it's a little after 3. Do you want to do a review? Do you want to leave and I'll record one? What do you want to do?
I think we should leave. I like the Zoom video idea.
Okay,
Yeah.
that's fine. I'll go over everything and then I'll just post it. I'll probably do that now. So, okay.
Just a question: are a lot of the drugs, are those in the charts? Or are they like someplace else in the chapter? Like,
It
does
kind
the
of
chart
varies.
Give like enough information if you find
Yeah, yeah. But when I do the review, I'll kind of talk about what they're looking for. Okay.
Haven't